Alright, so we're moving on to psychiatry now. Anyone doing both of the courses right now is actually benefiting big time because we just finished psych in this step one book. And now we're moving on to basically revising it all in CK. Starts off first with childhood and adolescent disorders. So, of course, first things first, ADHD, right? Persistent pattern of excessive inattention and or hyperactivity and impulsivity typically presents between 3 and 13 years of age, basically anyone under 15. More common in males and often shows a familial relationship. Presents with core symptoms that can be divided into the following two categories. The main things are in the name ADHD, so inattention, which is attention deficit, and then hyperactivity. So that's literally the name of the disorder perfectly gives away exactly what you're looking for. Right, so inattention exhibits a poor or short attention span in school, work, and play, which is usually where this gets caught and leads to the patient coming in. Displays poor attention to detail or careless mistakes, has difficulty following instructions or finishing tasks, is forgetful and easily distracted. This is often confused with just not having the ability to learn, but that's not the case here. They're just not paying attention. Hyperactivity and impulsivity is the fidgeting you'll see, leaving the seat in the classroom or running around inappropriately or just cannot play quietly, talking excessively, not waiting for their turn, and interrupting others. This often, the running around inappropriately often shows up in questions as some child that may be like running around the table or running around their seat before they sit down, or they may already be sitting and then they get up and run around their chair, so stuff like that. Anything that even remotely feels ritualistic is also part of this hyperactivity. Symptoms must be present for more than 6 months in at least two independent settings, so home and school, or school and maybe some other daycare they're at, stuff like that. Age has to be under 17. All right, if they're under 17 years old, then the diagnosis requires six symptoms from either category of the core symptoms. If they're over 17, then diagnosis requires 5 symptoms for either category. It doesn't really matter how many symptoms, you don't really have to necessarily count. The age is the bigger part, and either way it still gets classified as ADHD, so it's not really that significant. Like, they're trying to make this sound very complicated, but it's really not as complicated as they're making it sound, and there's no reason to make it this complicated. Why the psych department would even want to do a difference between 5 or 6 symptoms is pretty insane too, because what difference does one more symptom make? Symptoms must be present before 12 years of age. This is critical, right? So the onset of symptoms should be from elementary school. So you remember you start first grade at like around age 5 and you're done with 5th grade around age 10. So elementary school, there should have been some symptoms there. Symptoms must cause functional impairment, which again, you don't want to confuse this with something autistic, right? So autism spectrum will also be an answer choice here, but the impairment that they have should only be due to their own inattention, right? So social, academic, or occupational impairment. Alternative causes of inattention and or hyperactivity must be ruled out, such as substance abuse, which is very rare here. It could be in high school, there could be substance abuse, but usually these questions are going to be talking about someone 12 years or younger. Lead toxicity, definitely want to rule that out. So if they have weird tummy pains or something in the question, then you consider that. Or if they're fatigued and anemic, you consider that. Hearing and visual impairment, thyroid disorders, sleep disorders, and if they have absent seizures, which will also be a potential answer choice. These are all patients that will also present somewhat similarly. However, there are key symptoms we're looking for, right? We're looking for key symptoms to pick ADHD: inattention and hyperactivity. If you don't see these things, then it's probably not ADHD, and it's most likely one of these other issues. Treatment, if they're 4 to 5 years of age, the best initial treatment is this behavioral therapy. Add medication if behavior doesn't improve. If they're over age 6, the best initial treatment is pharmacologic therapy plus behavior therapy. So for pharmacologic stuff, you want to now look at stimulants. First line are methylphenidate, dextroamphetamine, amphetamine salts, right? Any of these things are very good stimulants. And when we talked about amphetamine in the step 1 class, I mentioned that amphetamines are also prescribed for weight loss. So you see it's written here as an adverse effect. Right, there are 2 key medications that cause weight loss: as an adverse effect, but it's not really an adverse effect, but it could be. Basically, any effect you didn't want from the medication is considered an adverse effect, right? So this is a very nice adverse effect, weight loss. Amphetamines cause it and topiramate causes it. So both of them are actually prescribed together often to help obese patients lose weight. Amphetamines being a stimulant, they don't let you sleep well, so you get insomnia, you can get anxiety, you can definitely become very irritable. Um, Headaches, I'm not sure about that part. I guess it does happen. Tic exacerbation, of course, if the patient has Tourette, they're going to be getting even more tics because, again, this is a stimulant. And decreased growth velocity, right? Normalizes when the medication is stopped, though, so it's no big deal. Basically, you don't want to put this 6-year-old on amphetamines for too long, not a long-term medication. Alternative non-stimulants are atomoxetine. That's another answer choice. That's a great answer choice. It's an NRI, norepinephrine reuptake inhibitor. Can be tried first because of the negative side effect profile of amphetamines. So you could try atomoxetine first. And then the alpha-2 agonists, clonidine and guanfacine. Remember, alpha-2, its job was to turn off all your sympathetic output. So you stop alpha-2, then you theoretically indirectly turn on sympathetic output, which is fight or flight stuff, so you should have more attention capability. Bupropion, which definitely can help with the ADHD aspect, and then TCAs, which you obviously would never pick as an answer because the side effect profile of TCAs is terrible as well, right? So the cardiotoxicity, the comas, and the anticholinergic aspect of things is pretty bad. All ages continue regular diet. Sugar and food additives are not considered etiologic factors, right? And that's it for that. So children must exhibit ADHD symptoms in 2 or more settings, and that's another critical thing. So how are you going to, in questions, differentiate ADHD from one of these other things? One, the symptoms should be appearing. First of all, the symptoms, right? So symptoms are going to have to do with the AD and the HD, both things, right? Attention deficit and hyperactivity should both be present. So if someone only has a sleep disorder, they're not necessarily going to be hyperactive. If they have only absence seizures, they're not going to be hyperactive. Thyroid disorders, if they have hypothyroidism, they're not going to be hyperactive. So these are some things you can obviously easily use to rule out these diseases. And then the symptoms should be the same exact symptom present in 2 different settings. If you have absence seizures, you can get absence seizures in 2 settings as well, but the symptom would still be the key thing you're looking for, right? So again, the name of the disease, thankfully here in this case scenario, is very beneficial. It gives away exactly what you're looking for: inattention and hyperactivity. The UWorld table tells you the same kind of stuff. Just remember the medications, right? Atomoxetine, any alpha-2 agonist, and then the amphetamine stimulants. Right? You don't pick TCAs. TCAs are not safe. I can't imagine how they would have to word a question to force you into thinking TCA is the best answer choice there, because that's like really hard to do. But again, always remember the TCA side profile, and if it looks like TCA is the only thing left to give because they already gave everything else, then I can imagine TCA would be an answer choice. But that would be ridiculous that they've tried everything and nothing worked. If you try amoxicillin first and it doesn't help, then you move on to methylphenidate or dextroamphetamine. And if that doesn't work either, combined with behavioral therapy, then at the very end, maybe TCA is something you would try. But I highly doubt that they're going to write the question like that, because by that point, something should have worked. Next thing, autism spectrum disorder. Developmental disorder characterized by impairments in 2 major domains: social interaction and communication, and 2, repetitive restricted behavior, interests, or activities. More common in men again, or male kids. Severity is based on the level of support required for each domain. The DSM-5 does not distinguish among the pervasive developmental disorders. Right, so here's a URL table for all the things you look for in ASD. Deficits in social interaction and communication. So you're going to have reduced interest in socialization, reduced empathy, inability to form relationships, impaired language development, inability to understand social cues, and poor eye contact. So at this point, what you look for, basically, any child that's doing these things, very concerning, very, very concerning. And at this point, you should start noticing that this deficit is not an attention deficit, so you can rule out ADHD at that point, right? Prognosis is best determined by language development. restricted repetitive patterns of behaviors, interests, or activities. So now you're looking for this repetitive pattern thing, which again can have some overlap with the hyperactivity that you notice in ADHD patients. So you have to be careful with that as well. It should have some difference, but not necessarily. So you're going to see highly fixated or restricted interest, inflexibility to change, hand flapping, increased or decreased response to sensory input, like not having a indifference to temperature, excessive touching, smelling, or adverse response to sounds. Symptoms must impair function, and symptoms must be present in the early developmental period, typically under 3 years of age, so before even starting preschool. Conditions that produce symptoms suggestive of autism spectrum disorder must be excluded. So you have to rule out other things that look like ASD. So intellectual disability. Remember, autism spectrum disorder is not an intellectual disability. Usually they are actually pretty intellectual. They just can't form social ties. They can't really communicate very well, and they have weird behavior. But they're very intelligent. They're not necessarily unintelligent. Hearing impairment you have to rule out every time. Selective mutism is another diagnosis where it's just a refusal to speak only in social situations. So any child that gets diagnosed with selective mutism, it's selective. That means that there are places where they talk all the time. They basically talk regularly and normally in situations where they're comfortable. If they're not comfortable, they don't talk, right? Rett syndrome, similar to ASD, X-linked disorder characterized by marked physical and psychomotor regression at approximately 6 months of age after normal development. So these questions have regression, right? Rett is regression, where basically what happens is they might be reaching milestones, developmental milestones, while they're growing, and then at a certain age they no longer match those milestones and they start going backwards. They start regressing. And since it's X-linked, this is really only seen in males. A female can be a carrier, but if she's a carrier, she'll have minimal symptoms. She might have some symptoms, but minimal symptoms, nothing debilitatingly bad. Sorry, what am I saying? Yeah, actually, this is the other way around. Sorry. Because of how bad this is, actually, it's always a girl. It's so bad that if a guy gets it, they die. Right? So that's the thing, actually. In these questions, this is a very unique kind of X-linked problem here. Usually, when you have X-linked disorders, you really only expect to see the issue in a guy, right? Because men only have one X chromosome, so as soon as they have that disorder, they get the disease, and then you see the symptoms. But if a guy has this Rett syndrome X-linked disorder, the guy actually dies. The little newborn boy would just not make it at all. So this is actually predominantly seen in girls, where the girl has one X chromosome that is Rett syndrome, the other one is normal. They'll have these symptoms, and this is actually the only symptomatic accident you'll see. The only time ever you'll see questions where this is an X-linked disorder, but the only patient exhibiting symptoms is a female, right? In this disorder, in Rett syndrome, any guy that would have Rett syndrome would be born and die within the same period of like the first week or so, possibly even be a stillborn. So a very unique kind of thing here. It's due to a MECP2 gene mutation, which is also often an answer choice, really annoying answer choice. But overall, Rett syndrome is a very easy question because this is not going to be somebody attending school or anything like that. It'll be a child with developmental disorder where their milestones were initially being met, now they're regressing. So maybe they had started saying 2 words, now they're not even able to say a single word. That is usually the number one most common symptom you'll see in the female patients with Rett syndrome, because speech delay is the most common delay overall with milestones. Other than that, they also won't have the general aspect of having any meaningful activity or side play with others, anything like that. They may not even be able to walk. They might be actually reaching that 16 or 14-month milestone, but they can't walk. So that's also a delay. Should be a pretty easy question. It's never really that difficult, and the first thing you look for is the patient a female. Other than that, ruling these things out from autism spectrum disorder should also not be so difficult. So if we look at this question, this is a pretty interesting question on UWorld on Rett syndrome, and they teach this other thing in one of the answer choices as well. So an 18-month-old girl is brought to the emergency department after having a seizure in daycare. Staff reported that she suddenly fell down and started shaking, but they also noted that she seemed quieter and repeatedly pulled at her hair over the past month. Her mom says my daughter used to say mama and papa and babble away, but has begun to talk less in the past few months, which is the giveaway for Rett syndrome, right? That's a regression right there. She's also become more needy, wanting me to feed her rather than using a spoon herself. So that's a physical regression. Medical history is significant for 3 ear infections in the past 10 months and one previous seizure thought to have been a febrile seizure in origin. Family history is significant for early onset Alzheimer and in the patient's paternal grandpa and retinoblastoma in a paternal cousin. She is afebrile and other vital signs are fine. On physical exam, she makes eye contact with the physician but speaks no words. Very abnormal for an 18-month-old girl. She is noted to have a lurching gait. What is the most likely diagnosis for her? It's just Rett syndrome. There's nothing else wrong with her besides the fact that she's clearly developmentally regressing, right? Her loss of speaking skills and the ability to feed herself after initially having those skills, her repetitive hand movements, and her gait disturbance after a period of normal development are suggestive of Rett syndrome, a neurodevelopmental disorder that occurs mainly in girls due to mutations in the X-linked MECP2 gene. Seizures occur in most patients and are increasingly prevalent with age. Now, a few people in this same question picked this other answer choice, Landau-Kleffner syndrome. Never heard of it, right, until I did this question, which is characterized by the regression of language skills due to severe epileptic attacks. Language skills typically deteriorate, though, at a higher age, right? So this is a very close differential to Rett syndrome. Obviously, this could be an answer choice. This is something NBME would love using as the correct main answer. So age obviously always plays a big deal. Rett syndrome is so severe that any male with the X chromosome dies and any female with the X chromosome will exhibit really bad symptoms by the same age as which we saw in immunology, that you lose your maternal immunoglobulins, right? It's the same thing. By 6 months above that 6-month period, they start regressing. So if the patient is 3 to 6 years old and now they're regressing, then you pick Landau-Kleffner syndrome. Right, and it's also mainly a language different, right? So you see Landau language, you think of it like that. It's a language regression, not everything else. And they should be having severe epilepsy, which is what's causing their brain to kind of lose their ability to talk correctly. Okay. So move on. Next thing. Then we have disruptive behavioral disorder. So this includes conduct disorder, oppositional defiant disorder, and disruptive mood dysregulation disorder. 3 different conditions that are better discussed in the first aid for step 1. So let's take a look at them here real quick. So first one was it, they talk about it over here a little bit, but not in that much depth. So conduct, oppositional ODD, and disruptive mood. Okay, so conduct disorder: repetitive, pervasive behavior violating societal norms or the basic rights of others, aggression of people and animals, destruction of property, theft. After age 18, often reclassified as antisocial personality disorder. Treatment for both is just psychotherapy, right? So antisocial personality disorder is another case scenario that is just a sign that your conduct disorder never went away. You had really bad conduct disorder and just never went away, and it became a part of your personality, right? So then at that point, antisocial personality disorder comes into click, which we'll see when we look at all the personality disorders, and we'll see what that's all about, right? One key thing here is the violating societal norms and the basic rights of others. So these people have terrible conduct, which we've always used to talk about what it means. Like it's conduct is not a rare term. It's a typical term that we don't use that much in everyday life, but with kids we do talk about it, right? So with kids we say that we have to make sure everyone has the right conduct. All the kids should be acting right? So aggression and destruction of property and theft are considered really bad conduct, which gets you thrown in jail. But of course these kids are under age 18, so they can't really necessarily go to jail. They can, depending on how bad the destruction of property may have been, they could go to juvenile jail. But overall, if they get diagnosed with conduct disorder, then they'll just be getting psychotherapy, which is usually what happens, right? So that's your conduct disorder. Next one, ODD, oppositional defiant disorder. So this one is just defiance, okay? Enduring pattern of hostile, defiant behavior toward authority figures like the principal, the teacher, any security guard, lunch lady, stuff like that, but without serious violations of societal norms. They just don't want to listen to whoever has authority. That's it. They just don't, they want to be the boss. They don't want to listen to anyone else that is the boss. So that again is just psychotherapy. Don't ever end up picking a medication for conduct disorder or a ODD. Okay, these are both bad conduct, but conduct disorder is really bad conduct where you end up in jail. And here you're defying the police officer. So you don't really end up in jail per se, but you're defying the police officer, right? And it's not something that bad. So you want to make sure you don't end up picking medications though. There are always going to be these questions about these two topics where you're going to have a bunch of answer choices, psychotherapy, medications, and whatnot to pick from. But psychotherapy or cognitive behavioral therapy, or a very specific type of cognitive behavioral therapy that you may have never heard of, may be an answer choice. That's what you pick, not the medication. Now, when it comes to disruptive mood dysregulation disorder, there you have to pick medications, right? So this one, DMDD, that's actually a problem, right? So DMDD is the other one, disruptive mood dysregulation syndrome. This one is onset before age 10, so basically in that 1st to 5th grade period. Severe recurrent temper outbursts out of proportion to situation. Child is constantly angry and irritable between the outbursts. Treatment is to give them stimulants and, if necessary, antipsychotics, right? Because any child who has temper outbursts is, without a doubt, psychotic and needs medication, right? There should not be temper outbursts. And this is very common, unfortunately, right? Depending on how a child is raised, a child could have really bad temper outbursts, either because they saw temper outbursts in their parents or because that's just what was allowed to happen. If you let one temper outburst take place and you don't obviously punish the child and teach the child better, then those temper outbursts will just keep stacking up. So then that ends up being a big problem. So here they further go on. Psychiatric comorbidities are common, PTSD and stuff like that. But again, these things are always common in question stems as well. They might mention some of these other things. Your job is to consider whether or not it actually matters, whether or not to weigh it in the question, how much you want to let it weigh, what does it really mean? Because you still have to be able to diagnose these things just fine. So in here, they talk about the things the same way again, right? ODD, just basically having bad hostile behavior toward authority figures. That's all this is, right? This may progress to conduct disorder. Conduct disorder is then that hostility also becoming a violating behavior, pattern of violating things, which of course definitely gets you in jail. If that conduct disorder doesn't get better, then after age 18 it becomes a part of you and you are now labeled as antisocial personality disorder. And then DMDD, pattern of severe recurrent verbal or behavioral outbursts that are out of proportion simply due to angry mood, right? So mood dysregulation, it's in the name. All right, all three of these are classified under disruptive behavioral disorders, and only the first two you really do psychotherapy. Here they say psychotherapy is the first line treatment for all of them, but with DMDD you got to be careful. You actually need medication for this because they're so angry that if you try giving them psychotherapy, they have anger outbursts there too. So the only situation at that point ends up being to do medication, antipsychotics or stimulants like amphetamines. And you have to be careful with them. Even with the stimulants, amphetamines, for example, we saw that they can make you irritable. So amphetamines may actually worsen it. If that happens, then you switch over to an antipsychotic instead. Here we have a question about head growth deceleration. So a 16-month-old girl brought to the office by her mom due to breathing problems for the past month. Mom says she struggles to catch her breath when she gets excited. At other times, she seems to be holding her breath. The mom is also concerned that the girl, who started babbling and saying a few words at age 1, has spoken very little the last few weeks. So whenever that ever happens, again, that sounds a lot like Rett syndrome, especially because it is a female patient, right? So we saw the same thing here in this question above as well. Medical history is significant for a simple febrile seizure at age 11 months and an upper respiratory tract infection at 6 weeks ago, which is typically found in most kids anyway, so it's perfectly normal. Physical exam, she has a brief period of hyperventilation followed by hypoventilation, which passes within 30 seconds. Vitals are fine. She makes brief eye contact with the doctor, but rocks back and forth and says nothing. She repeatedly twists her fingers and has an unsteady gait, which is also things you see in Rett syndrome. She would most likely exhibit what other features? So the question doesn't ask you what's the diagnosis now. This is like a second degree question. What else would she have? And only 50% of people got this question right. A head growth deceleration, right? Because remember, in Rett syndrome, if you're regressing, so is the size of your brain in a sense. So head growth deceleration was the answer choice here. Rarely is that actually fully verbally taught in most of these books where they talk about Rett syndrome. So this was a good question to teach you that. 15% of people chose happy demeanor, which is something you would see in Angelman syndrome, which is one of your imprinting disorders, and a musty odor, which is one of your biochem enzyme deficiency disorders, right? So this isn't that either. Her respiratory abnormalities, loss of verbal skills, repetitive movements, and gait disturbance suggest Rett syndrome, right? That's all this is. There's nothing else to really worry about. And the last sentence tells you deceleration of head growth is common and leads to microcephaly, autistic behaviors, and seizures. So there you have it. You know, two different really good questions, straight up telling you what Rett syndrome is like, and then this other thing that's a lot like Rett syndrome but in older kids. Right. Next thing, intellectual developmental disorders. So now this has your Down syndrome, fetal alcohol syndrome, Fragile X syndrome, right? Disorders of cognitive, social, and practical functioning associated with male gender chromosomal abnormalities, congenital infections, teratogenic issues, and inborn errors of metabolism. All those things fall under here. Down syndrome, trisomy 21, is the most common chromosomal cause of intellectual disability. Number one cause of genetic intellectual disability. But Fragile X syndrome is number two cause of genetic intellectual disability, but the number one cause of inherited genetic intellectual disability. So you have to make sure you understand the terminology there. You don't inherit Down syndrome. Down syndrome is basically a mutation, but it is the number one cause of genetic intellectual disability because it's more common than Fragile X syndrome. However, Fragile X syndrome in that case must be the number two cause of genetic intellectual disability. But in another case scenario, Fragile X syndrome is also the number one cause of inherited intellectual disability. So very important to understand that aspect. Fetal alcohol syndrome, the most common preventable cause, number one preventable cause of intellectual disability, because although this is not inherited or genetic, it is something that is actively caused. A mom does this to their fetus by drinking alcohol, right? So definitely preventable. No identifiable cause is found in most patients with intellectual disability. Patients have deficiencies in multiple domains, intellectual deficits, and now you're seeing lack of intellect, right? We didn't see lack of intellect in any of the things we've looked at so far. All of those things, autism spectrum disorder, the disruptive disorders, and the very first one, which was your ADHD, these people don't lack intellect. They may not be doing well in school, but they're not unintelligent, right? They're just not doing well in school because they're not listening. But here with these intellectual developmental disorders, now this is the only place where you actually have lack of intellect. So if you ever get a question where they're telling you, and it's not that the student must be doing bad on an exam or something, they're literally telling you the child cannot learn. That falls under here, right? Doing bad on a test is just the result of not listening when you were supposed to be learning, but not being able to learn at all is an intellectual development issue. Adaptive functioning deficits like poor hygiene, social function, activities of daily living are all poor. Onset is going to be during developmental period, right? So under 18 years of age. Severity of intellectual disabilities, well, determined by level of support required to address the impaired adaptive functioning, right? Even like, for example, in today's time, patients with Down syndrome are running full jobs, taking care of themselves, even able to live alone, right? So that is all the result of certain Down syndrome patients being able to actually learn with the right amount of teaching. They're able to go to special schools where they're taught everything, taught how to behave, taught what's good, taught what's bad, with the right amount of conditioning and the right amount of example behavior. They end up just fine, right? They are able to learn, but it takes much more effort to actually get them to learn. And if not taught, then a Down syndrome patient will just learn what they see. And if they see bad things, they're going to be doing terrible things, which is why it's often very dangerous when parents completely disregard their Down syndrome child. and let them watch whatever they want to watch on TV, because then they stumble upon YouTube and they see some violent shit and they end up thinking that's normal behavior. They assume whatever they see is normal behavior, and that's a very critical thing you have to teach them when they actually go to school, that this is normal and this is not normal. So that's all the severity aspect is, but you're rarely ever going to get a question where you have to determine the severity, right? Mild, moderate, profound, that's all going to be pretty commonsensical when you look at a question, but it's all based off of how much support they need. Differential diagnosis is going to include the things we already looked at: specific learning disorders, reading disorder being the most common one because it's very hard to learn to read. It's also very hard to learn to talk, but that comes at least somewhat more naturally. Talking comes a little more naturally than reading does. All right. Treatment, primary prevention, educating the public about possible causes of intellectual disability. Right. Primary prevention, basically against drinking and doing any kind of drugs while being pregnant. Right. So providing optimal prenatal screening and care to mothers. And then second is treatment measures, right? Family counseling and support, speech and language therapy, occupational and physical therapy, behavioral intervention, educational assistance. These are all things that in America are fortunately available for Down syndrome. And Fragile X syndrome patients are not really gonna, it's very unlikely they're gonna make it to anything above age 20. Down syndrome patients tend to live to about age 50 because Down syndrome is associated with a bunch of other issues too, right? There are some GIT issues, there are some cardiac issues. So their lifespan, the average is, I believe, around 50, right? So they do make it to quite a distance in life. So this stuff thankfully is available in America for Down syndrome patients. In other countries, Down syndrome patients are practically just disregarded. It's just very sad. Here, at least they are somewhat, not somewhat, they are fully provided what they need to. If it's a learning disorder, remedial therapy directed toward the specific deficiency they have, right? Whatever they can't learn, you teach it to them. I have worked with a company here in America where I was hired to teach a whole class of learning disorder students. These were all students that had the specific learning disorder in mathematics. So I had to show them how and why everything works the way it works, get them to understand it. And not a single one of them had a problem with actually like wanting to learn. They did want to learn. Their only issue was that they truly could not grasp it. It could be the easiest of things. Of course, for their age, it wasn't that easy of things, but they just could not grasp it. And it's something that requires extreme patience to work with them as well. So that was a pretty good, well-paying job as well. It was a pretty good experience to see what that's all like. And again, with pediatrics, every time I've ever worked with kids in any environment, it was more and more reassuring to me that I could never handle going into pediatrics, because the number one issue with anything pediatric related is how is the family, right? So most of these kids, their parents would come in, and it was pretty disgusting to see what kind of people unfortunately do become parents. So you got to be very careful with that aspect of things. There's only so much you can do within the school setting. Then they go home and everything gets fucked up. So now here we have a bunch of questions, so let's dive into it. These are all related to some of the things we just looked at. First question here: a mom brings her 4-year-old adopted daughter to the office due to concerns about her adjustment to preschool. So considering the age and gender and it's adopted, we got 3 factors to work with already. She was taken away from her birth mom, who was abusing cocaine and alcohol at the age of 2, and moved to an orphanage. So hopefully the mom wasn't abusing any of that when the mom was pregnant with this girl either. She was adopted by her current family 6 months ago. Prenatal history is unknown. The adoptive mom reports that the patient doesn't interact with classmates and prefers to play by herself. Could be normal, could be weird. At home, she hardly speaks with the family and stays in her room, where the mom has seen her hoarding toys and food under the bed. The patient is able to dress herself, copy a triangle, write the letters of her name, and walk down the stairs without aid. So those are all pretty good aspects of development. Everything's working. Her mom says sometimes she doesn't pay attention or listen to me. At other times, she will start to cry for no reason. She doesn't like being hugged or picked up. Nothing I do seems to comfort her. Again, these are all seeming like pretty normal response to having a really bad childhood, right? Where she never really got to develop, I can assume she never really got to develop a very good relationship with her original mom. And then living at an orphanage at age 2 can't be very fun either. And now being with a new mom is just a very, unique experience because you're with a stranger who you're now having to call mom, right? So all of that makes sense. You have to sympathize with that in the question to really see how pathological the issue is. On exam, the patient is sitting quietly, playing with various toys in the doctor's office, which is totally good. That's great. That's normal. She's not sitting there doing something autistic or doing something repetitive and Rett like or any of that stuff. She makes some eye contact. Speech is normal. Excellent. But answers are brief with little facial expression. Okay, because she's not feeling that good. Vital signs and physical exam are normal. So you can see in this question, they're mentioning everything is normal. They keep saying all these things that are normal, right? So you really don't want to pick an answer choice that sounds very far-fetched where the child would not be normal. She's in the 50th and 60th percentiles for weight and height, so even growth is normal. What is the most likely diagnosis in this patient? So all this is, and only 40% of people got this right, reactive attachment disorder. That's all this is. And the name tells you itself that makes sense, right? The other things that people chose are a little extreme where these things would not necessarily be normal. Autism spectrum disorder. I would only pick autism spectrum disorder if I saw the child doing things that were repetitive, somewhat weird, not maintaining something that's normal, but everything in this child was normal. So that didn't make sense. 20% of people chose it, and 15% chose PTSD. But remember, PTSD is an SD. There's PTSD, and then there was also another ASD that we looked at. All kinds of things that we looked at in psych when we did the step 1 videos. Those things were related to some level of real trauma that affected them, and it's usually something you see in adults. This girl hasn't, although what's happened to her is pretty traumatic for sure because of the relevance to her age and what she should be getting, relative to the treatment a 2-year-old girl should be getting, her treatment was pretty bad. But it's not like she witnessed murder, right? And nowhere in the question does it say that she was beaten or something like that. So no reason to really pick PTSD, nor is she exhibiting any post-traumatic stress, right? She's not. She's just doing things that seem a little weird. Like hoarding toys and food under the bed is something she probably did at the orphanage too, right? So that's the kind of stuff you want to think of. So if we read their explanation, the child's history of neglect, social withdrawal, lack of positive response to attempts to comfort, and decreased emotional responsiveness is consistent with reactive attachment disorder, which may develop in young kids when abuse, neglect, prolonged institutionalization like the orphanage, or inconsistent care disrupts the development of a healthy, secure attachment to caregivers. These kids seldom seek comfort and do not respond to attempts to comfort them. Right? They know they're not going to get comfort. It's very sad. So then they don't even try looking for it, and they definitely don't recognize it when they do get it. Other symptoms include lack of social responsiveness, lack of positive emotions, and episodes of unexpected irritability or sadness. Another possible outcome of early neglect is disinhibited social engagement disorder, characterized by overfamiliarity and an unhesitant approach to unfamiliar adults. Other disturbances commonly seen in children with a history of abuse or neglect include poor emotion regulation, poor toileting and sleep difficulties, anxiety, aggression, and hyperactivity or impulsivity. So this is another answer choice right there, right? Disinhibited social engagement disorder. Disinhibited social engagement. So that's literally the perfect terminology for someone who over familiarizes to unfamiliar adults, right? Talking to strangers as if you love them and they love you. That's disinhibited social engagement disorder, which is another thing that could have occurred with the same girl in the same scenario. ASD and RAD. What is ASD? Oh, autism spectrum disorder. Yeah, ASD and RAD both have social and emotional deficits. However, autism spectrum disorder has restricted interests, stereotyped and repetitive motor mannerisms, and language impairment, while she has a history of neglect and hoarding, which is common in kids who have suffered neglect. Young kids with PTSD can have emotional or behavioral disturbances and social withdrawal, but PTSD would not explain her stunted emotional development or lack of positive response to caregiver attempts to provide comfort. Right, so a couple things that are missing there that don't really add up to the scenario we're working with. Next question here, 32-year-old man. So what's this about? 32-year-old man comes to the office for evaluation of ADHD. Although never treated, he had behavioral problems starting in kindergarten, frequently getting into trouble, both at school and at home for not listening, talking out of turn, and inability to sit still. Many of these difficulties persisted throughout high school and college. The patient continues to struggle with distractibility, forgetfulness, disorganization, and impulsivity. He is concerned that ADHD is affecting his relationships and work performance and mentions that he has been passed over for promotion several times, because you don't get promoted if you have ADHD, simply because of how they're acting, right? He has a history of alcohol and cocaine use disorder from age 18 to 24, and family history of alcohol and opioid abuse in his parents. Okay, patient does not use alcohol or any drugs. He hopes that medication can help, but is concerned about taking anything addictive. All right, what is the most appropriate next step in his management? So most patients that come into any psych clinic or psych department in general never want to take something that has one of two qualities: either it's addictive or it has really bad side effects. Unfortunately, most medications in psych do have really bad side effects. Few of them are addictive, though. Very few. It's not that they're addictive, but they're when a patient comes in and says addictive, they often also are referring to something as something they'll have to depend on, not just addictive. So medication dependence is also another thing that no one really likes, right? No one wants to be dependent on any medication for life. So that's another thing you kind of try to watch out for. Okay. All right. So what do you give this patient? Well, same thing we just looked at earlier today, right? Atomoxetine. This was the first thing we looked at. So ADHD. We looked at all the medications for this, and we saw you could give them stimulants, you could give them atomoxetine, or you could give them an alpha-2 agonist. Those are the best things to go with. You want to kind of try avoiding bupropion. It has some bad side effects, and you definitely want to avoid TCAs for the really, really bad side effects. So it was really easy to just pick atomoxetine as the answer, and you just move on. You don't want to really pick an amphetamine for this patient either, because it might cause him to look bad at work. Remember, amphetamines make you, what I like to call, it makes you hangry and angry. So you will be hungry because you're not really going to feel like eating, which is what causes the weight loss. But then that also causes anxiety and irritability, which makes him look very, very upset and pissed off. Right? So all of that in the work environment is definitely not going to help him get a promotion. So atomoxetine, 40% of people, 15% of people chose cognitive behavioral RT, whatever that is, and then 20% of people chose the amphetamine, methylphenidate. So why not the amphetamine, like I explained, and let's see what they say. ADHD frequently persists into adulthood and can cause significant impairment in occupational, academic, and social functioning. Stimulants are the most effective treatment for adult ADHD, but have potential for misuse or addiction, especially in patients with a history of substance use disorder. So he himself doesn't use anything, but his family has. And even though, remember, you don't always believe everything your patient says, so there might be a chance he does use drugs. Among non-stimulant options, the norepinephrine reuptake inhibitor atomoxetine is considered the treatment of choice. Atomoxetine is not addictive and has been shown to reduce ADHD symptoms and improve executive functioning and quality of life. Other non-stimulant options with efficacy for ADHD include bupropion and TCAs, which have more side effects, so you don't want to use them. Right, and amphetamine in general you just wouldn't want to use because of the anger it can cause. It just wouldn't look good on him. All right. Next thing, these are all related to sexual behaviors in pre-adolescence, another group of things that can show up. And I think what is the last thing here is Tourette. So because first ACK doesn't mention so many things, these are some extra things that you should know about. So right here I have a note: young kids are naturally curious about their bodies, and it is developmentally normal for toddlers and preschoolers to touch their own or other young kids' genitals. Fix this correctly. Occasional genital self-stimulation is also common, as is asking about reproduction, playing doctor with other kids, dressing in the typical clothing of other gender, and attempting to undress themselves or others. Right? None of those are straight up considered a problem or extremely dangerous or concerning. These behaviors are usually brief and distractible and should not be stigmatized, but rather redirected if socially inappropriate. These behaviors typically decrease as kids approach adolescence, when they become more aware of social norms and expectations and have an increased need for privacy. There are, however, sexual behaviors that are of concern in young kids, such as precocious sexual knowledge, preoccupation with masturbation, excessive or aggressive talks about sexuality, and stimulating genital to genital, oral genital, or anal genital contact. Such reports should be explored further in any of your ethics type questions. Anogenital trauma, coercive sex play, or repetitive UTIs with no medical cause should raise concern for possible sexual abuse. So here's a question, and then this next one too. I think one of these questions somewhere here is, this one is related to that. Well, let's jump to this one right here. So this one, 17-year-old girl comes to the office for a routine maintenance evaluation. She is thinking about having sex for the first time. She has been in a relationship for 6 months and would like to have a physical connection with her boyfriend. She has not felt pressured by him and feels comfortable and safe in the relationship. She has fantasies often about having sex with her boyfriend and masturbates 4 or 5 times a week. She has no history of partnered sexual activity. What is the most appropriate response by the physician at this time? Now, this is a really important lesson for a lot of physicians, especially those coming from other countries outside of America, because this is actually handled in really weird ways by a lot of doctors who forget that you don't put your cultural and religious beliefs into answering the questions that a patient is asking. So the correct answer here was just, this is an ethics one, and it says, wondering about when to have sex is very normal. What questions do you have about sex and your body? Straightforward, super simple. That's all you're there for. Right? 60% of people chose it. 20% of people felt for deciding when to have sex is up to you, but we should talk about ways to protect yourself from sexually transmitted infections. Again, this is definitely what a lot of doctors say. And then there's a whole group of doctors that say, oh no, you're too young for sex, don't do it. That's also not your job, right? At least it's not your job with someone who isn't too young for sex. She's fine, she can have sex. Someone that would be getting the advice of, oh, you're too young for sex, would have to be maybe like someone who hasn't even started menstruating yet, right? Keys to promoting open discussions include providing a private setting, assuring confidentiality, normalizing discussions of sex, removing stigma and discomfort by being non-judgmental, and avoiding assumptions by using open-ended and gender-neutral questions about identity and sexual behaviors. All of which a lot of people and too many physicians in today's time have no idea about. She has been forthcoming about her thoughts of becoming sexually active with her boyfriend. The best response is to convey that it is normal to have questions and begin an open-ended discussion of any concerns that she may have. This should come first. Then the physician should redirect the conversation to a specific counseling regarding contraceptive options and STI prevention. Right? These are topics which may inadvertently discourage the patient from bringing up her own questions and concerns. Right? So you don't want to scare the patient initially. You want to let them talk about what they want to say. You want to read your patient, not have your patient read you. Right? So read your patient. Let them tell you everything they want to say to you. Hear them out. Then say the things that you want to say as a physician, and then give the advice that you should give. Right? That's one thing. This question here, 9-year-old girl is brought to the office by her mom for assessment of bad stomach aches. She has missed 5 days of school in the past few weeks due to intermittent abdominal pain that is achy all over and worse in the morning. She has not had nausea, vomiting, diarrhea, or constipation. Appetite is poor. Mom reports that her daughter used to be talkative and outgoing, but now she declines invitations to play at friends' house and instead naps after school. She has been distracted in class lately and less engaged in group activities. Her dad lost his job 3 months ago and has been home. The mom says things have been hard financially. It doesn't help that her dad started drinking again. When interviewed, the patient is withdrawn and makes poor eye contact. When asked if she feels depressed, she says everything will be better when no one has to take care of me anymore. So that's like a suicidal thought. What is the most appropriate next step in her management? Obtain an emergency assessment for possible hospitalization, because that's a suicidal thought. A 9-year-old girl having a suicidal thought means that she'll probably commit suicide, right? It's different from an adult saying that. It's more likely with someone unstable and irrational, like a 9-year-old girl, right? Her social withdrawal, poor appetite, impaired concentration, and sleeping during the day are all concerning for depression. And then on top of that, her self-addressing of her death, right? Childhood depression is often associated with somatic symptoms, as in her stomach aches, because kids often have difficulty recognizing or discussing their emotions, so they manifest it somatically. She should be assessed for child abuse due to the change in behavior in the context of family stress and parental substance abuse. Hospitalized if she has suicidal ideation, which she does. Poor psychosocial support, which she also does, or lack of follow-up. Pharmacotherapy with SSRIs is most effective and well tolerated. Right? but she's probably going to also have to be reported to CPS, where Child Protective Services is probably going to take her away from that family, because we have a mom that isn't really doing a good job with the girl and a dad that's an alcoholic now, right? And an alcoholic dad living in this house is already a problem. This one is also MDD, but now it's a 16-year-old girl. So these are atypical types of MDD questions, right? You could tell from step one, this is not the type of depression question you typically see in step one. Now you're seeing depression in all kinds of other out of whack, uncommon presentations. So right here we have 16-year-old girl brought to the office by her mom due to concern about her behaviors and grades. Her mom says she used to be a good student, but over the past few months, her grades have dropped and she doesn't seem to care. She has been in the annual school play since first grade, but recently quit the drama club because I am not into it anymore. I can even remember my lines anyway. Right? So, can't even, excuse me. Can't even remember my lines anyway. So she's kind of having a tough time. She avoids her friends and spends a great deal of time in her room with the door locked. Okay, that's actually something that's often seen with 16-year-old girls. She goes to bed early, wakes up late. That's a little weird. Takes naps when she gets home from school because she feels tired. So that's excessive sleeping. Mom reports that the patient has been more irritable, fighting frequently with her younger siblings. She responds, I'm the oldest, and my brothers annoy me all the time. I just don't have any privacy at home. Okay, that's understandable. She has no medical conditions and doesn't use tobacco, alcohol, or illicit drugs. Physical exam shows no abnormalities. She is cooperative but appears distracted at times and asks for several questions to be repeated. She appears fidgety and restless, frequently shifting in her seat and shaking her right leg. What is the most likely diagnosis? So this was actually a little bit of a hard question in my opinion. In general, because of the way she's acting and there not really being a cause for it, it's usually a case scenario depression, right? There's no real cause. Nothing has happened, right? She's just suddenly acting like this. So this is a 16-year-old girl that is now going through MDD. That was the correct answer that only half the people got. 50% of people chose this. 20% of people chose normal adolescent behavior, which I can respect because a lot of her behavior is what a normal 16-year-old girl would do. However, there are some things here that are key. She has many findings of MDD, such as her anhedonia regarding the drama club, hypersomnia, lack of energy despite sleeping so much, poor concentration, extreme irritability, and psychomotor fidgeting, which she's doing near the end of the question. The last sentence was the true giveaway, in my opinion, that this is not normal adolescent behavior. If they ever tell you in a question that a patient is fidgeting, that's not typical of a 16-year-old, of a 10-year-old, of a 5-year-old. They shouldn't be fidgeting. You know, when we were really, really young, when we showed up to the clinic in front of a doctor and the doctor was in front of us, we sat pretty straight. You know, you may not remember, but if you actually do pediatrics and you see your patients, most patients, especially any of them that are normal, are just gonna sit there as if they're sitting in front of the president or something, or they're like in big trouble or something. Most kids just sit still and they look at you. You know, they maintain that eye contact, whereas they keep telling you they're, you know, this girl was asking the doctor to keep repeating questions. That's pretty fucked up. I don't want to repeat what I already asked. Fuck that. You know, and on top of that, they'll also say in many questions that the patient is not maintaining eye contact, not really listening well, constantly looking around everywhere. This isn't a zoo. This is a clinic. So when these patients do these things, you immediately think it's not normal, and then you start placing them into autism or into some kind of other childhood disorder, you know, and you start figuring out what's happening. So the only place to really place her, as the list of these symptoms is being told in the explanation, is just MDD. Like her, depressed adolescents may be irritable rather than sad. That's another atypical feature. Okay, so we saw one atypical feature here. Depressed youngsters, anyone under 18, could have somatic symptoms because they don't know how to express themselves. And here, instead of being sad, they're angry. Right? That's actually even something you could see in depressed adults also. The degree of functional impairment at school and in relationships must be assessed in adolescents with suspected MDD. Although adolescents are frequently moody and desire privacy, her behavior represents a marked change from her baseline. Her symptoms are not normal as they are causing academic dysfunction and social impairment. See, a lot of the things she was doing were normal, but then she should be doing great at school. She should not really be quitting the drama club and stuff like that. So even this part right here, she used to be a good student, but then in the last few months something has drastically changed. It could have been that something silly happened at school that was a big deal for her. I'm calling this silly, but maybe she really liked some guy or something and he said no, and then she went into depression. So something silly like that could have happened that actually had a big impact on her, and then all of a sudden you're seeing that her baseline was at a certain point, baseline functionality, and it dipped. Let me just see something real quick. Next question we have, let's see, the bottom one right here, starting to lag. 5-year-old boy is brought to the office due to behavioral difficulties at school. His grandma says this past year has not been easy for him, but he's been hitting other kids and breaking their toys. So he's doing something really bad. That's definitely not so good. But I want to know what has not been easy for him. He was adopted by his grandma a year ago after his parents died in a motor vehicle collision. So that's pretty bad. He attends the same school but no longer wants to play with his friends or join group activities. He wakes up a few times a week crying about monsters and asking to sleep in his grandma's room. He can ride a bike and draw complex shapes, so developmentally he's okay. Vitals are within normal limits and he is tracking adequately on growth curves. Physical exam is unremarkable. He is restless and rams a toy truck into a stuffed animal repeatedly while his grandma speaks. That's pretty weird too, right? He makes poor eye contact and answers questions by saying, "I don't know," despite his grandma's encouragement. You see, this is the kind of shit I'm talking about, right? No one should be doing this. I never did this as a child in clinics. This is not something I did. This is not something most of any of you guys watching the video may have done. This only really occurs in those of us who may have had some kind of psych issue at a younger age. Making poor eye contact is never acceptable. Okay, this is usually the slightest way a question can give away that something abnormal is happening. And the question is doing a pretty good job spelling out the problem here. This is PTSD, right? Answers questions by saying, "I don't know." What is the most likely diagnosis? Just PTSD. Very straightforward. Surprising that only half the people got this right. 20% of people chose RAD, reactive attachment disorder, but we saw what reactive attachment disorder was like. This was reactive attachment disorder, where this girl was similarly adopted, but she was having reactive attachment disorder not because of some kind of trauma, but because she actually was having a difficulty establishing a connection. It takes time. Adoption is a very slow process where it can take a very long time before the person you adopted actually accepts you, and that part is a very difficult part and very stressful part of adoption. This is PTSD. They clearly spelled out a traumatic event. He literally saw his parents die in a car accident, so that's as traumatic as it can get for that point, right? And then he's having nightmares, which is exactly what happens in PTSD. You have stressful issues after the trauma relevant to the trauma. So he's having nightmares of monsters and he's acting out in his play an accident, a car accident, right? So this is straight up PTSD. His recurrent nightmares, violent themes in play, emotional reactivity with aggressive play, and social withdrawal after a traumatic loss are all suggestive of PTSD. Exposure to trauma can occur through direct involvement in or witnessing of a traumatic event or by learning about violent trauma to a loved one. Young kids with PTSD, whose memories may not be fully consolidated, often have nightmares that are not specific to the traumatic event. So he's dreaming of monsters, as well as repetitive traumatic themes in play with his car accident truck. They often struggle with emotional regulation and may appear easily upset or angered with little provocation, right? And we know what reactive attachment disorder is. We just saw it at the question on the top. Last question here, 5-year-old girl. So this one was also another question that only a few people got right. As you can see in CK, a lot of people are struggling with UWorld questions. Pay attention to the fact that in step 1 UWorld, you might often see a question has 70% or more people getting it right. It's not that they got it right the first time. Remember, more people repeat UWorld step 1 than they repeat UWorld step 2. So when you do UWorld step 1 a second time, and you pick the answer correctly, that actually goes into the statistics, right? So the statistics of UWorld step 1 is much more distorted than the statistics of UWorld Step 2. This is more legitimate. The UWorld Step 1 statistics is really hindered by two things. One, people repeating the test, so then they get it right the second time, and statistics get messed up. And two, because people have access to screenshots they use before they actually do the real UWorld Step 1, at which point it means they already knew the answer. Right here, it's legitimate stuff where people were actually doing this for the first time and they fucked up. So only 40% of people got this question right. I found that really weird, but it makes sense because of the way the answer choices are. So it's very keen for you to know the vocabulary of psych, right? That's what happens here. 5-year-old girl is brought to the office by her parents due to a problem at school. Her teachers report that she's very quiet in class. When she does talk, she frequently uses the wrong verb tense and is occasionally teased by her peers. Her parents report that she was slow to speak as a toddler, but they were not overly concerned as they had assumed that she was quiet and shy. She has a friend with whom she plays after school. She's able to dress herself, skip, tie her shoelaces, and draw a triangle. So she's got all these good social and developmental things. On exam, she's initially shy, but warms up as the interview progresses, which is normal. She's doing good. Her speech is clear, but her vocabulary is limited, and she uses simple sentences. She can count to 10 slowly. What is the most likely diagnosis? Everything is fine with her. She's doing great. She just can't talk, right? That's just language disorder. That's it. A lot of people fell for a specific learning disability. I can see what they were thinking, but that's not what's happening here, right? This isn't a learning disability. It's just a language disorder. She most likely has language disorder, a common developmental disability of childhood that occurs in about 10% of kids. It's very common. It's characterized by persistent difficulties in comprehension and or production of spoken and written language. It may involve the rules, content, and or functional use of language. As in her, typical symptoms include a markedly limited vocabulary, errors in tense, and difficulty producing sentences with developmentally appropriate length and complexity. So you just can't speak well. Early intervention, including structured language therapy and stimulating language development at school and at home, is beneficial. Specific learning disability is the type of students I was working with back in my old job I was talking about, where all the students I was working with were the ones that were having difficulty learning math. This is something that she may be at risk for as the demands of reading and writing increase. Remember, she's only in the first grade right now. So that was actually the reason I personally wouldn't pick that answer choice. I don't know what she's having difficulty learning because she has just started learning. It's first grade. What do you do in first grade in America? Not much. Very little things, not much. Most days go napping and playing and just talking to each other and, discussing 1, 2, 3 and ABC. That's it. So we can't really say she has a specific learning disability when we haven't actually made her learn crazy things yet. So SLD may be something she's at risk for as reading and writing requirements increase as she goes to second and third grade. But there is insufficient evidence to make this diagnosis because you need standardized achievement tests to actually diagnose this, right? She only has a problem with language, not math, which is something I added into the explanation. Right? Usually, most students that do have a specific learning disorder at maybe age 10, when they're done with 5th grade and they've taken their first standardized test, it's usually either language or math, not anything else. Math because there's some creativity involved, there's the necessity of a good teacher, and remember, math is all imaginary. It's not a real thing per se. It was invented, aka it was invented, or you could say math was discovered, but it's not something that's solidly a real thing. Whereas language similarly is also imaginary. It's not something that was a real thing. We made this up, and different people around the world made up different languages, right? So these are all things that students struggle with, children struggle with when they have difficulty actually grasping that creativity, all right? We didn't see that here. So this is a great question to help you learn the difference between language disorder and specific learning disability, where you're looking for a child that's been trying to learn but can't. She didn't have that. She's only 5, okay? Key things. So age is always hyper important in all of these things, right? Very good questions here. Last topic for this first section is Tourette syndrome, right? Very easily, a lot of people often confuse this with things, but this is actually a very high-yield topic, and you want to make sure you get this down correctly. Tourette, all we should think of as soon as we think of Tourette are tics, either physical tics of shaking in certain ways or vocal tics, right? Disorder characterized by both motor and vocal tics, more common in men, shows a genetic predisposition associated with ADHD, learning disorders, and obsessive compulsive disorder. Symptoms begin under 18 years of age and cause social or occupational impairment. Now, the general public usually knows Tourette syndrome very well. There have been popular movies in almost every single culture that had a very prominent actor or actress incorporated with Tourette syndrome. And there have been multiple TV shows, even in America, as well as other cultures and countries, where the prominent main character, the protagonist, had Tourette syndrome, right? But they're usually leading a major role. The most common role given to most Tourette syndrome patients is being a teacher. So that's to tell you that learning is usually not the problem for them. Intellectual development is usually not the problem for them. Diagnosis requires these things: multiple motor tics, one or more vocal tics, tics present for more than a year, and tics must be recurrent, so they occur multiple times a day, nearly every day, right? This is all we're looking for Tourette syndrome. Treatment: behavioral, right? Habit reversal therapy is most effective. It is, if behavior therapy fails or tics are severe or disabling, the next step is pharmacologic management with what feels like psych type medications, right? They're using dopamine type medications. They're all anti-dopaminergic agents. Okay, so the first group we're looking at is tetrabenazine, a VMAT2 inhibitor that decreases the uptake of monoamines, which includes dopamine. This is actually preferred over dopamine blocking agents because it won't cause tardive dyskinesia. Remember, dopamine was necessary for correct movement, right? The D1 and D2 receptors with the subthalamic nucleus, you had the direct and indirect pathway, all of that stuff from neurology step 1. So every time you talk about dopamine type medications, you want to think of those things in tardive dyskinesia and all those different side effects, the Parkinsonian side effects. So a dopamine uptake inhibitor is preferred rather than a dopamine blocker because that leads to dyskinesia. So you pick tetrabenazine. This is the most common thing for tics. For Tourette, dopamine blocking agents, which are antipsychotics, are a little more problematic. You could have side effects here, but fluphenazine, risperidone, haloperidol, these are all helpful. Severe or refractory tics, which can be your question, so they may have already been taking tetrabenazine, now it's getting worse. Treat with haloperidol or pimozide. Right? These are both. Pimozide is often an answer choice because no one knows what the fuck that is, so it often shows up on your answer choices, and you might be like, I've never heard of that. So you spend a little more time thinking about pimozide because everyone knows haloperidol already, right? Remember all the mnemonics too. The thieves fly high to remind you of the high dose typical antipsychotics, and then the low dose typical antipsychotics. You want to know those very well. Go back and revise those if necessary, right? Because here you're not revising pharm. This is step 2 now. So by this point you're supposed to know it very well. So go back and revise those from step 1. And we'll look at it too once we're done with more of the psych stuff. We'll go back to step 1 psych and look at it. Actually, in step 1 course, we're up to psych pharm. So when I'm done with that, I'll probably add the same video into the step 2 playlist as well as the pharm aspect, because it's the same thing we'll be looking at. There's no pharm section in first aid step 2. And then you can also use alpha-2 agonists, which are less effective at tic reduction, but they have a better side effect profile. Very often you use both things together. So you would use the alpha-2 agonist as well as the tetrabenazine together, so you can have a better reduction in tics, right? The issue with tics is not that it's anything like a disease that's killing them. It's an aesthetic problem, right? It's a socially unaesthetic issue that as a teacher, if you're having tics, most students are probably gonna laugh and make fun of you. You know, and it becomes a really difficult thing in the occupational area, right? So that's generally all there is to it. And again, don't get confused because they will exhibit ADHD and OCD type behaviors, but the real root issue is the tic. Remember, ADHD and OCD don't have tics. So if you have tics and ADHD and OCD, then the real issue is Tourette syndrome, right? So that's all there is to that. And then in the next video, we'll go into our big boys, the psychotic disorders. Thanks a lot for joining, and I'll see you guys later tonight at 6 p.m.